So let's begin with the first case. Good morning, everybody. So the patient was a 53-year-old female who was referred by an outside optometrist for evaluation of corneal opacities on the right eye that were found on a routine exam. Patient had no visual complaints. Her past medical history I will mention later. Her past ocular history.
And then probably syphilis, TB should always be on the list.
Sure. Good. Good. So going back to her past medical history, the patient was diagnosed with sarcoidosis in 2001 based on bilateral hilar adenopathy, and she had a borderline ACE level. She also had a history of zoster, which happened 2 years ago, and it involved the right part of the forehead. Apparently, she was followed by ophthalmology at that time, and there was no ocular involvement. And here are some of this lesion on the cornea before December of last year. So ocular involvement in sarcoidosis is seen in up to 50% of the affected patients. Corneal findings are not very common, and the most common one is band keratopathy. It might be related. The patient was a 19-year-old male with recently diagnosed Hodgkin's disease, stage 3B, had a 3-month history of supraclavicular adenopathy on both sides, and had some workup. It was found to be the nodular sclerosing type. Had some B symptoms, that's why it's B stage. And on the CT scan, he was noted to have some hypointense lesions on the spleen, so that's why this S is here. So he was referred to the Kowa Institute in the beginning of September for evaluation of decreased vision on the left eye for 5 days. Had no pain, no flashes, and no floaters. He was going to be started on ABVD margins on both eyes. It was more significant on the right eye, which was the eye that he had a 20/20 vision. And the left eye, you can also appreciate some blurring of the disc margins, and it was already a little bit pale temporarily. So at this point, basically just summarize, a 19-year-old male with recently diagnosed Hodgkin's disease presenting with iritis, keratitis, and bilateral blurring of the disc margin. Some of the differential diagnoses that we thought could be a paraneoplastic syndrome given his recent diagnosed Hodgkin's disease and this presentation with keratitis, iritis, and involvement of the nerves. Another possibility would be optic nerve infiltration from Hodgkin's disease, but this would be very rare. There is only one case report in the literature from 1982 that they presumed was a Hodgkin's disease affecting the nerves. And we thought about infectious etiologies causing some sort of infiltration of the nerves as well.
Could I ask?
Malignancy, and so VZV is still very much a possibility. We reported a few cases of this out of Emory about 10, 15 years ago of patients who presented with that.
So when he presented here, his oncologist was contacted, and we talked to him and told him what was going on. So MRI of the brain and orbits was ordered on the same day. He had a B scan, and the next day he had an LP with CSF analysis.
And I think our
I'm not totally
best
sure
diagnosis would be paraneoplastic.
Could be. Elias, you're about to say?
Yeah, I'm just wondering about the significance of the corneal lesions, and as far as I know, and my information is probably antiquated compared to the rest of us, but when
EBV, neurologic complications in general are very rare. There are 8 case reports in the literature reporting optic neuropathy as a complication of EBV infection. And on those Hodgkin's disease, they didn't do a biopsy of the nerve at that time, but they thought that it was related to the Hodgkin's disease. And there are a few case reports of optic nerve infiltration from...
And in retrospect, you have to really, I don't know anything more about that case than what you just said, but 1982 was prior to the time that it was known that the VZV and HSV caused R. And actually that was the year, 1982 was the very first year that that association was made.
It often gets, when someone starts thinking Hodgkin's has anything intraocular, it ends up getting mixed up with some other kind of tumor or Burkitt's or something. Basically, there are only a couple case reports, and most of them have been questioned.
Yeah, as Dr. Singh, he's not here today, but he mentioned the other day, if you ever see case of Hodgkin's disease in the eye, think about something else, probably the diagnosis is wrong.
Right. I agree with that.
Yeah. So here, this is a case of non-Hodgkin's disease.
Far away from your LP as you're going to get in the central nervous system. What you're depending upon is the cells that float around in the CSF go through random.
The patient was a 71-year-old female. She was referred to COI for evaluation of blurring and distortion of her vision on the last picture that we have from our patient when she came here at the end of September. As you can see, some of the lesions have decreased in size compared to the initial presentation. She's somewhat atrophic compared to the initial presentation. And at this point, I will open up for discussion. Yeah.
Could you explain to me again what the quantiferon
Type
test
4
detects?
hypersensitivity reaction, and they would release interferon gamma. And they quantify the amount of interferon gamma that's released, and
Does it detect current activity or evidence of prior infection?
it can detect prior infection as well.
Okay, well then, I think you already knew the patient had TB, so I'm not sure why you ordered the test.
It was ordered by infectious disease.
Well, I'm not sure why they did.
They did because they feel that if there is active tuberculosis, that the quantiferon goal would be positive. But like Breno said, sometimes with posterior uveitis, you do not have reactivity in the peripheral.
Okay, but with inactive TB, can it be positive too?
It can.
Yeah. And
Are quite variable, as I showed, and the ocular lesions can mimic other entities. High index of suspicion might help, and the delay in management without proper anti-tuberculous therapy might carry grave consequences.